so can you see this video? So this is a video that will try to illustrate what Anil said, that elbow flexion and biceps function are two different things. So this is a rather old video, but you can see elbow flexion, right? So this is in an infant, and I think he's now 2 or 3 months old. And so this is exactly what Anil is trying to tell you. What do you think about this function? Does anybody want to share their thoughts?
It's hard to know until you isolate the arm at the side.
Absolutely, absolutely, yeah. And so what you see is that the child uses wrist extension and also pectoralis major to combine to a flexion movement. And now we see this child now a little bit older, and we're going to see the same movements. And again, it's the question, what do you think of this function? You see there's very strong, very clear elbow flexion, 90 degrees against gravity. So, would you operate this child or not?
I'd be tempted.
Of course.
Have you seen this video already, Anil?
No, it is the same video, just that the child is held upright.
Yeah, but
that is the trick that we have to use in order to eliminate this trick of the pectoralis major.
Yes, yeah. But this is a trick video because this is the first outpatient check after nerve surgery. So this is 6 weeks after we cut C5 and C6 of this child.
Yeah. So he still has elbow flexion, which we thought was coming from the C5-6.
After we cut C5 and C6.
Yes.
So this is all trick movements.
Honestly, Willem, if I can butt in again. Hello?
Yeah.
Yes.
This was the same point that I was laboring during the meeting in Leiden, that it doesn't matter whether you excise the neuroma or not. The function is not going to get downgraded because it was the function seen before surgery was not contributed to by the axons traversing the neuroma.
Yeah, of course.
And therefore, cutting the neuroma is not going to cause any hardship to the parents. We should not be afraid of cutting the neuroma off.
But that depends also on the age of the child. There will be some axons when you would operate at 9 to 12 months, but there are no axons at 3 to 4 months.
At 9 or 12 months, you probably would jump to nerve transfers in any case, isn't it?
Yeah. So we call this the Steinter effect according to the Steinler surgery, so that the elbow is flexed with the wrist extensors and not with the biceps or brachioradialis or brachialis muscle. So, in essentially, this is what it's all about. It's about trying to predict the natural history, and here you see this natural history and I put a favorable prognosis here in the green line and an unfavorable prognosis here, and if you have a surgical intervention, then first function may or may not go down, and when you do this at 3 months of age, it might be difficult. It's easier to cite when it's 9 months of age, but in our view, we are afraid that the end function will be.
Don't worry, I gotta be ready for the meeting tonight anyway.
Okay, who's that?
So now I want to talk to you about the electrical recovery. And we talked about the rule of the biceps muscle at 3 months of age.
Except with the kids.
But the EMG at this age of 3 months is too optimistic. So what Martijn did, we performed a study, and we saw 48 kids early in their disease, and we tried to see them at 1 week, 1 month, and 3 months. So we serially followed them up, and we scored 13 items, clinical items, EMG items, and then we looked at follow-up of 2 years or at surgical findings. We defined a good versus a poor outcome, and then we tried to correlate these 13 items to the eventual outcome. And we came up with a 3-item test at 1 month. And we had a very good, correct prediction of final outcome already at 1 month of age. And we employed 3 items, which I will show you now. The first item is elbow extension at one month of age. If there's no elbow extension at 1 month of age, you know it's going to be a bad prognosis. These are, of course, the more extended lesions. If there is elbow extension, then we look at elbow flexion. If there's elbow flexion at 1 month of age, of course, the prognosis will be good. And if there is no elbow flexion, then we perform the EMG of the biceps. And if there is there electrical activity at 1 month of age, then there's a good prognosis. And when there's no electrical activity at 1 month of age, then we consider it a bad prognosis. So this is how we employ the EMG, because we know if we do an EMG at 3 months, the predictive capacity of the EMG is lost. So we now have the clinical rules that if there's biceps recovery at 3 months of age, the shoulder will recover excellent. Gilbert said he reverses this, so if there's no biceps recovery, he says you should perform surgery. We additionally added the triceps muscle at 1 month of age is a strong predictor of poor outcome, and also the EMG at 1 month of age can predict good or bad outcome. And now we're going to talk about imaging. So this is a 10-year-old paper when we still routinely use CT myelography. And you see here the lesion extent. So on the left you see the C5, C6 lesions, and on the right you see C5 to T1 lesions. And you see that even in very simple C5, C6 lesions, we saw in 40% of cases, we saw avulsions or partial root avulsions. And of course, this increases with extent of the lesion. Now we have MRI that we perform under anesthesia. And here you see on the right side, you don't see the root filaments, so they are absent here. And you can also see the pseudomeningocele here on the right side. So the MRI is excellent for depicting root avulsions and maybe even good to see the neuroma. So this is a coronal view of the brachial plexus. The lesion is on the left side. And the nice thing is that, of course, you have the normal brachial plexus at the right side. So you see C5, C6, and you immediately see that C7 is missing on the left side. So the root is missing. And when we go further in the course of the brachial plexus, you see that you still have some nice nerves here on the right side, but the nerves are gone here on the left side. And then you see here the neuroma formation on the left side, while you still see C5, C6, C7 on the right side. So this is not perfect yet, but it might give you an indication of what to expect during surgery.
Yeah.
During surgery, we do the intraoperative assessment. So we try to really look at the lesion severity per root, whether it's an accident-mesos, neurotmesos, or root avulsion. And of course, accident-mesos and neurotmesos, this is not black and white, but there are different shades of gray in between. So we look at the foramen. Is it empty or not? So this means that we have a root avulsion. If there is there enough neuroma formation? We stimulate the nerve itself. We stimulate the proximal branches to see if there's a root avulsion. And this is the biggest neuroma I could find in our photo collection. So this is not too difficult. And here you see, unfortunately, this is a black and white picture, but you see nicely there's no neuroma formation at all. So these 5, 6, and 7 roots, they are all avulsed. We don't use intraoperative neurophysiology, and we do use frozen section examination. And we use it for the proximal stump and in the distal stump. And the goal is, of course, to determine where to cut the neuroma. And this is an illustration, but you can see the same thing when you look under the microscope. So this is in the paper from Howard Clark's group, and you see that in 23% of children, they actually performed a proximal or distal recut of the nerve, and then the histology of the stump increased. So we expect that this also correlates with a better outcome. So we use intraoperative histology always.
Can I ask a question about that to jump in?
Yes, absolutely.
It's Kyle Everland. First, I want to apologize about not being on mute earlier, and I very much have enjoyed this talk. My question is, do you have the same pathologists review all of these cases, and how much do you trust their assessment of the histology? Because one of the challenges that Justin and I face when we do these types of cases is we get different pathologists all the time, and it's really hard to know the veracity of the information.
Absolutely. Now we have one pathologist who does let's say 80–90% of all these cases, and only when he's away that that we get a different pathologist. So he sees the majority, and we trust it a lot. We trust especially how the root looks, how the architecture is. Is there still neuroma formation or not, or is it a nice do you see fascicle bundles? So we want to really end up seeing fascicle bundles without neuroma. So this is the first thing, and the second thing is that we check the myelination, and the myelination we see preganglionic lesions. They have a decreased myelination, and it's difficult to say what you trust more. Is it the MRI or is it your pathologist? And I think if you have a very clear root avulsion on your MRI, then sometimes we don't even bother to harvest the histology, because maybe there are some axons still connected, and you can maybe leave them better in place, and then do a nerve transfer after all. So I think that if you have a good MRI, but it also depends on the quality of the MRI, then for root avulsions we trust the MRI, but especially for neuroma formation and to delineate the proximal and distal extent of the neuroma, we trust the pathologist. Yeah. So this is of course all very very simple. If you have a damaged nerve in neuroma, you take out the sural and then you put it there, and it looks wonderful. So neurolysis. When do we do neurolysis? We never do any deliberate neurolysis. The only thing is when we operate, let's say, a 4 to 4.5 month child, and we find that during surgery there's not very much neuroma formation, that the superior trunk and C5, they do react onto stimulation very forcefully, and we don't want to we don't want to cut it. Then we think this is a child who will have a late recovery, and then we do say we do a neurolysis. But of course, this is just it would be better to call it a surgical exploration of the lesion, because to neuralize will not help, in our opinion, to improve neurological outcome. But this doesn't happen often. I think it's maybe 10% of the cases with just a pure C5, C6 lesion that we end up and say, well, we did the surgery too early. But in our opinion, it's better to do this and have 10% explorations than wait longer in all the other 90% of kids. You can do nerve grafting to the original target, or of course to an alternative target when that root avulsion, for instance C6 to C8. We do extraplexal to interplexal nerve transfers, and also intraplexal to intraplexal nerve transfers. So a short word on our results. So this is the excellent recovery at 3 months. Then at 1 year you see this, and at 3 years you see an excellent recovery from the first lesions. And this is the same thing that we see when we look at melee outcome hand to head. We see 75% can reach the head. We see 87% can reach the mouth. Only a very small amount of children will not have a recovery of biceps flexion. And when you look at hand function, you see that around 60% of children will gain a hand function of Raimondi grade 3 or better. So the timing of surgery is important, and of course it makes things easier if you wait longer because the lesion becomes more clear. But we think that it might affect the nerve reconstruction. We don't know this, of course, but this is what we see in adults. We see it in the lab, and also the stress of the parents increase with time. So that's why we really try to do an early assessment of severity of the lesion and to perform nerve repair early. Of course, there's no randomized controlled trial, and every surgeon will have its own paradigm to decide for surgery or not. This is a very elaborate scheme by Howard Clark, but it's still, is it progressing or not? Is it fast enough or not? And if not, do a nerve surgery. So, and then the main question comes, because in adults, nerve transfers have taken over the market in favor of nerve grafting. So why not do a simple overland transfer at 9 months of age when there's no recovery of biceps? Because in our view, it does not optimally target elbow flexion. And we currently we are in favor of grafting the superior trunk to reconstruct elbow flexion and also shoulder function. Because if you reconstruct of C5 and C6 instead of doing just a simple overlap, you also have brachialis muscle, you also have brachioradialis muscle, you re-innervate the superior part of the pectoral muscle, and also if you reconstruct C6, then you might improve sensation of the hand, because the thumb and index, they are the key fingers for tactile input to the brain. And recently we found that if the sensation of the hand is correlated with a decreased handedness of these children. So these children, they had a decreased hand function in C5 and C6 when you look at sensation and sensibility. For shoulder function, of course, the triple transfers, we know that they work, the oberlans and the accessory to suprascapular, triceps to axillary, but we still favor grafting. This is different in adults now, but in children we still favor grafting because children do better. And if we don't have to sacrifice trapezius function, why should we?
This is where I'm going to take opportunity to initiate an argument. So I've gone back and forth on the spinal accessory to suprascapular when there are plenty of routes to graft. Obviously, it takes longer to get that shoulder function when you do it through a graft. But I think why not? And I think Anil pushed me again, saying his results for spinal accessory to suprascapular were better than his grafting results in the children. What is your experience? Which is giving you the better outcome for the shoulder?
Yeah, we had an old paper and we said we couldn't find any difference, and that's also in Howard Clark's patient series, that there is no real difference between grafting and transfer. I think there might be a little better outcome after nerve transfer, and we are currently looking into our complete series, and we will analyze a lot of patients. But the difficulty is that we have confounding, and one of the main confounders is that we perform grafting when we don't have root avulsions, and we perform nerve transfer when we do have root avulsions. And this might change the way in which the child recovers. So we are now currently trying to split it out for grafting and transfer, root avulsions, not root avulsions, because we think that the initial lesion, also we did a lot of suprascapular accessory to suprascapular nerve transfers also in kids we don't have enough grafts. But of course the accessory to suprascapular is a fantastic operation, and it really works. And in a lot of instances you have double innervation also from your C3, C4 spinal roots. So this is difficult. We have not decided yet, but
Yeah.
From the material that we have now, we cannot say we are in favor of one against the other.
Okay.
Justin, can I butt in?
Yes.
Even when I'm dealing with the C5, C6 with both roots ruptured, I prefer to put the spinal accessory to the suprascapular, for one reason being that I find that I'm not confident that my root will provide separate supraspinatus function. In other words, it will not be a co-contraction with the pectoral or the biceps. Whereas, so I prefer to have the innervation of the rotator cuff completely separate. Secondly, as Willem said, it is quite easy to find a Y sort of supply to the trapezius. That is from the lower. There are deep cervical plexus elements which seem to be joining the spinal accessory nerve, and they can be kept in continuity for the lower trapezius, and you do not.
And he's gone.
Anil has left Earth, I think.
He did. He
Effectively, completely denervate the lower trapezius when you cut the spinal accessory for the. No, I'm sorry. Hello.
Okay, you're back.
Can you hear me?
Now I can.
Yeah.
Yes.
Yeah. In the cases of C5, C6 avulsion, you don't get shoulder contractures. Therefore, the internal rotation contracture will not happen as often, and therefore the amount of external rotation that you regain from the spinal accessory to suprascapular nerve transfer will be better than the one that you will get in the C5, C6 ruptures. I mean,
Absolutely.
This is a common observation that when there are root ruptures, quite often the patient also does develop a contracture at the shoulder pretty early.
I absolutely agree, and we are now trying to look into this and really measure degrees and everything. So there's someone doing all this statistical work as we speak. So I hope within half a year that we can provide actual numbers.
You know, Willem, my main misgiving always is that I am stuck in a situation where my results entirely depend upon the diligence of the parents, and quite often they are not insistent enough, and therefore the patient develops an internal rotation contraction nevertheless, and that's quite disappointing for me. I mean, maintaining follow-up every 3 months, and then suddenly finding that I need to do surgery to shorten the coracoid process, that is really disappointing.
Yeah, I have a new pressure to leave the spinal accessory alone with Bassem in town.
Oh yes, of course.
He's always mad at me for taking away his trapezius that he can do magical things with later on.
Yeah, certainly.
And there was also in the NARICAS meeting, there was one contribution to use the, if you have a good C7 root, to perform a fascicular transfer of C7 to.
Yes, I've tried that, but I'm not a very big fan of that.
I tell you, I've done that in adults a handful of times, and I've been very disappointed with the results in adults because it's the opposite direction. Yeah.
Yeah. Okay.
Yes. You can't ask the
babies, I feel like,
do
can do better than adults.
Yeah.
Yeah.
Oof. No, that is experimenting. Gosh. Because you don't have a fallback option if you do that in a baby.
Yeah. So to sum up our strategy, in C5, C6, and C7 lesions, we employ biceps function as a proxy for prognostication of shoulder recovery, because we think that reconstruction of the shoulder function is the most important of a nerve surgery. So when there's no EMG signal in the biceps, or if there's no triceps function at 1 month of age, then we say to the parents, well, we think this is going to be pessimistic, and we already tentatively schedule the MRI and surgically, because we have to do this way in advance for the anesthesia schedule. of course, we check the recovery at 3 months of age. And when there's no biceps function at 3 months of age, we perform the MRI and the surgical exploration. And of course, some kids after the MRI or in the waiting time for the MRI, they improve neurologically. And of course, then we wait. But then we already have a scheduled MRI date and a scheduled surgical date. And in more extensive lesions, we try to do the surgery as soon as possible. So our anesthesiologist really likes to wait around 3 months. So we try to do these surgeries between 3 and 4 months old. And then the inferior trunk is the main target in total paralysis. And I'm going to skip some slides now. So one second.
So while you're moving on, just another thought. In this population, as you know, when you explore and they're not avulsed, frequently we stimulate in the paralyzed muscle groups, right? But you stimulate proximal to the neuroma, you get very little response. You stimulate distal to the neuroma, and you sometimes get a nice response in the muscles.
Yes.
And I think this corresponds with some of these, you'll see these publications from time to time where somebody did a reconstruction at 3 years or at 5 years and got a result. You think, how on earth could they get a result? And that's because in these obstetrical injuries, these neuromas serve as a conduction block. You've got too many fibroblasts and not enough Schwann cells in there, and axons make it all the way to the muscle. So it makes timing become a little bit more ambiguous for the ability to recover muscles. And one of the things we do in our spinal cord injury patients is we actually directly stimulate the muscles to see how well they contract, because if they contract well, we know that the clock is not ticking. We can reinnervate that at 3 months, at 6 months, at 9 months, at 12 months. And in spinal cord injury, we've done it 10 years afterward. Good result. That's a concept I haven't ever seen applied to obstetrical injuries. And part of the reason is I'm always afraid of what's going to happen to the shoulder if I delay too long. I want to get it done early because, you know, the STEM is bringing me up to speed on the shoulder, but I always fear if I let a dysfunctional shoulder persist too long, that dysfunction will be worse in the shoulder dystocia malformation, I mean, the shoulder malformation and so forth.
And you get fractures and
yeah. Exactly, all the secondary complications, but it's not the primary complication we worry about in adults, that the muscle's not retrievable, because in so many of these kids, the muscle still is retrievable at late dates.
Yeah. Okay, so to conclude our surgical strategy in C5, C6 lesions, we aim at grafting. When we have a neuroma of C5 and an avulsion of C6, we try to separate the anterior and posterior rootlets. So this means that sometimes if you have a very clear avulsion, then you can separate ventral and dorsal rootlets. You have to cut out the ganglion, that's here. And we can do a direct coaptation sometimes from C6 onto C5, or we do one graft on the motor. And then we can target the sensory part either from C4, from the supraclavicular nerves, or another graft. So that means that we do a extrasensory access to the hand. And of course we do an accessory to suprascapular transfer when there's one root avulsion. If there is a avulsion of both roots, then we do the triple transfer, either pectoral or ulnar nerve. And then it becomes difficult because in C5, C6, C7 lesions, we try to graft all the 3 roots, and we take out the extra graft, we take the superficial branch of the radial nerve. And depending also on the aspect of C7, sometimes we do only a neurolysis of C7 and only graft C5 and C6. When there's a root avulsion of C7, we try to do a grafting from C5 or C6 to C7, and hopefully sometimes we can dissect this out and we only target the anterior filaments of C7, and we do the sensory branches to the posterior filaments. When we have only one root, then it really depends on the size and the match of C5 and C6 what we can do. And if the C5 is really small, then we do everything to the shoulder from C5. so to the posterior division of the superior trunk, and then we do a nerve transfer for the biceps. If C5 is relatively big, then we can do anterior and posterior divisions of the superior trunk, and also the accessory to suprascapular.
So what are you doing for the hand?
So now that if we have a C5 to C7 lesion, then usually the hand is okay.
Oh, I'm sorry, C5 to C7.
Yeah.
Okay.
So if we have more extended lesion, if we have a C5 to C8 lesions,
yeah,
then we think it's very important to really go deep into the foramen, because often you will get some reaction from the inferior trunk when you stimulate it, but when you go really proximal, then you find that all the stimulation comes from T1, and C8 is avulsed, is in situ avulsed. So you have to really go there and try to stimulate C8 separately. And sometimes we cut C8, leave T1 in place. And of course, you have to be very careful for the vertebral artery when you go so deep into the foramen.
So I'm glad to hear that that's what you do, because that's what I've been doing as well. But I find out that the group in Michigan and elsewhere are saying, forget T1, they cut the entire thing and graft it all again. If there's very weak T1 function, if you have a little bit of finger flexion, if I have anything, I want to keep it and maintain it. And some of the other groups' contention is it's such little function, just forget it, cut it out, and graft to the lower trunk so you make sure you capture everything.
Yeah, it also depends on your MRI. If T1 on your MRI is clearly avulsed, then you can, then if there is a very little function, then we take it out. But if we doubt, if it looks okay on MRI, then we leave T1 in place and we graft C8, sorry.
C8, yeah.
Because I think that neurologically C8 will go to your long flexors and T1 will go more to your intrinsic muscle. And for the function, because this will be an assisting hand, they will not play the piano.
Yeah.
So they will need the long finger flexors, not the intrinsics. So I think that C8 is a more important target also than T1.
Yeah.
So when there's a C5 to T1 lesion, use the best route for the hand. So if there's one route available, we use C5 entirely for the hand and do nerve transfer shoulder and for biceps. If we have two routes available, we use C6 for the hand and we use C5 for the upper trunk. And if we have three routes available, it really depends on the size and match how we're going to reconstruct this. And lately there's been a lot of advocates, and I know that Anil is too, for the contralateral C7. I think this is very difficult because we are not completely sure it's safe, and we are not completely sure it will end up in a good motor control of the ipsilateral arm. Because it will be the assisting hand, we don't want to take this risk. So only if there would be 5 root avulsions, then we would use the contralateral C7 for the hand. And in all other cases, we will use C5 or C6 for the hand, because we consider this the best route for the hand.
Okay.
So
when you use intercostals, are you a 3 intercostal, 4 intercostal for musculocutaneous?
The routine is 3.
Yep.
Yeah.
And do you ever use it for other targets other than the biceps?
I know that some people use it also for triceps, and we did some intercostals to triceps in a kid with acute flaccid myelitis, but we do not use it routinely for children with an obstetrical palsy. Also because we might be afraid to get...
I have not done a lot in babies, but I've done a handful. Do you see problems with late rib deformities after taking your intercostals?
We have seen a few, yes.
Yeah.
But I don't know if this is, the difficulty is, the trick is to leave the periosteum alone, not to cut the periosteum. In many handbooks in adults, you see you have to cut the periosteum and then find the intercostal nerves. We don't do that in adults, and we don't do it in babies either. And I think we've seen it not very often. I remember 1 or 2 kids. But the difficulty is also that you will see some asymmetrical rib cages, also because of the diminished volume of the pectoral muscles. So I think we made two times we made really an X-ray to verify that we have bridge gave deformity. Yeah.
The Willem, can I butt in? Hello?
Go ahead, Neil.
Yeah.
Yeah, so if there is distal function at the time of surgery, I generally operate a total palsy at 3.5 months. They like all of you do, I'm sure. They if there is already evidence of finger flexion, then I choose not to cut the T1. Because if you look at the so-called T1 hands, which lack extrinsic extension, it is only T flexors and the intrinsics. So if that T1 has started working already by 3 months, it would be really worthwhile leaving it alone and not grafting it. Whatever you add to the C8 is only going to add to the forearm flexors, but the essential innervation of the distal function, which has escaped the primary injury, will remain.
Yeah, but for this you have to really explore beyond the inferior trunk to proximal into the foramen. Yeah, and that
yes, of course, and I mean in a kid it's not that. Yeah,
and Howard Clark wrote a paper on the T1 hand. And he's very promoting, saying that T1 is the most important root of the brachial plexus. And I agree with him that it can be important, but there might be a difference from an analysis of a T1 root that has stayed intact and a T1 root that you surgically reconstruct. I think that they are two different things.
Yes, absolutely. About the contralateral C7, I haven't had the courage to do a contralateral C7 in a baby yet. My main misgiving again is that no matter what we do, the time duration it takes for a contralateral C7 to innervate the forearm flexors is going to be that much longer than the ipsilateral route. And to teach a baby, suppose he or she is operated at the age of 3 months, and I get innervation of the forearm flexors at 12 months, it is still difficult to make the child understand that it is a gesture on the opposite side which is causing the finger flexion. And
I have an N of 1 with that, Neil, that I did in San Diego, and I regretted it. It was a 1 root C5, and I did that proximal arm. I did contralateral C7 graft to lower trunk. The child did develop use of it and did innately learn to adduct the other arm. And interestingly, it all went to intrinsics, but adduct the arm and the fingers, the FCU would go and the hand intrinsics would contract like that, lumbricals with the fingers going straight without extension.
Yeah, but all of it will be a mass action, I'm sure. It must be very difficult to dissociate.
Not functional at all.
So I'm not very keen on that. I'm seeing my young adults with direct repairs of the contralateral C7 at long term now, and it is illogical to expect individual function distal to the elbow. It is all going to be a mass action, and it is going to be a helping hand with a sort of a hook grip. At least that is what I am at today. I don't get finger extension that consistently, only 4 out of 40 cases, which is a very small percentage. And therefore, I mean, getting prehension, as Wong talks about it, I'm not there yet.
Mm-hmm.
I don't know. What is your after Leiden? We have not had any meeting where we could get together and discuss. So I don't know what is the current scenario. There has been a gap of 1 year in between. Willem.
Yeah, you mean to get together and have a beer?
Yeah, no. What I meant was that opinions of people who are doing these procedures, I haven't been able to interact with anybody else who's doing contralateral C7 as frequently as I do. And so I really can't judge what is the consensus now. I know only my own results. I don't know other people's results.
Yeah, I know that at the ASPN that Anne Schwenker was enthusiastic about the contralateral C7.
That's who it was. It was Anne Schwenker. She was talking about cutting out the T1s, and she was also talking about using contralateral C7. I don't know what.
No, I'm a bit disturbed by her paper, so I don't want to comment.
Well, we're going to have to wrap up shortly. Did you get a chance to finish?
Absolutely.
I'm sorry?
Absolutely.
Okay. Hey, Willem, this has been really great. Thank you very much for sharing with us this morning. Would love to continue. And I'd like to twist your arm a little further because it's time to get together again. You have to come out here in June.
Yeah, June is too optimistic for us, I think, but we'll see about that.
All right, I'll keep nagging.
Yeah, yeah. That's
Oof. I have my vaccine QR code, but I don't know whether the US will let me in.
Well, you still got your mask on, I noticed.
Yeah.
It didn't work, huh?
Oh, I just got home. And I've not bothered to take down the mask, but it's okay. I'm at home.
Okay.
Hey, have a good day, y'all.
All right, thank you very much.
Thanks very much, Willem. It was nice seeing you.